nice to see everyone. Hi. Thank you for coming. I know you're all on holiday, right? So you're just here out of your own lovely goodwill. I thought I would speak for a few minutes about sort of a combination of the work that I do, also potentially some career stuff, just remembering being a student here myself now 12 years ago. No, 13. Wow. But if you don't mind, because we're a small enough group, I'd like to just start by hearing from you who you are, where you're from, and what you're interested in. So I'm just going to stick you on the spot.
I'm Simran. I'm a medical doctor and I'm from London and I'm doing the public health masters because I'm interested in promoting public and medical health.
Great.
Hi, I'm Lauren. I'm studying MSc Public Health as well, and I'm interested in being a physician scientist later.
Yes, my name is Evelyn, and I am also an ed and I do the Masters of Public Health, and I'm very interested in work around property, about entities, women's health, and leadership.
Great. And are you from England originally?
No, I'm actually a German doctor.
Okay.
I'm from Germany as well. Hi, I'm Stella. I'm doing HPPF, and I have a background in social science, so economics and political science, and I'm interested in efficiency and big tension between economic and public interest in healthcare.
Oh my God, yeah. It's your positive externalities are ranking highly in your language, yeah.
My name is Sabrina. I'm in the HPPF program. I'm from Germany as well. I'm a medical student and doing an intercalation year here, and I'm interested in health policy and access to medicines.
Great.
I'm Kevin. I'm from Netherlands. I'm studying epidemiology. I'm interested in infectious diseases and field epidemiology.
I'm Uchenna. I'm from Canada. I'm doing health promotion here, so my interest is health promotion.
I'm Wilson. I am from Rwanda, originally from Rwanda, but grew up in Belgium, and I'm interested in health systems. I'm doing public health.
Great.
So I'm Alice. I'm head of the alumni office.
Victoria, also like an alumna.
I'm Natasha, I work in the alumni office too. I also study my master's at the Institute of Education, focusing on education and development, and I'm interested in how education is planned during epidemics.
Great. Very timely. I'm Vanessa Kerry, and I am a medical doctor, and I did HPPF too, back in 2004, 2005, and really wanted to come here very specifically because though I love my country, I realized that our education system is extremely Americentric, and so for me to get engaged in global health, I felt like I needed to come and spend time in a different country with a different education and viewpoint, and also with a very multicultural environment and class, which you got much more here than unfortunately you did see in the programs in the States. And so felt really just like I was drinking through a fire hose while I was here. I don't know if you feel that way, but it just was a lot of new language and words and terms. And are you in Elias Marcialis' stuff? Have you done that? I mean, like, that was a whole new, understanding of the world for me. And so it's just very neat to be back and to be able to sort of talk about, quite honestly, what my time here set me up to start working on. So when I was 14 years old, I went to Vietnam with my dad, who was very involved in public service and international relations, and was very struck when I went to Vietnam about the degree of poverty I had seen there. And some of you are from countries that encounter this kind of poverty on a very daily basis. And it was just very stark, and there clearly was a huge need in these places that we work. And at the same time, as I started to go to medical school and grow up through the medical system in the U.S., there's clearly a lot of people who wanted to be engaged in global health and couldn't figure out how to do so. And I was one of those. So I sort of thought, well, gosh, if I go get my master's, maybe I can begin to understand some of the problems and the systems issues that are causing this issue and how to plug into that and make a difference. And so I started to learn about health economics. I started to learn about health systems. I started to understand some of the root causes of the problems. And when I went back to my training and finished it, I realized that we could potentially find a way to solve this need by actually bringing together sort of the supply and the demand and trying to create a solution. And so what we did is we started Seed Global Health. And what that does is it takes health professionals from countries that have enough, maybe not too many, but enough, and it has them live for a year in countries that have critical shortages of health professionals to embed as faculty. So they're not just going and providing clinical care, they're actually teaching and training and supporting the pipeline of young physicians, nurses, midwives in these countries who want and deserve quality education, who want to be advocates for their country and stay there. And it really is trying to help allow that pipeline to thrive. Because as you know, a lot of faculty are left these countries through brain drain or through conflict and genocide, through whatever the push or pull factors have been that have driven them out. And so as we did this, we started to recruit U.S. health professionals that would want to do this. But we also sort of decided that maybe we could challenge our government to do it as well, to step up what they were doing, because there was a lot of work through the CDC. So I don't know how many of you know how the U.S. government works. I do have a slide I almost feel like I should put up, because when we talk about global health in the U.S., most people think of PEPFAR, which is the President's Emergency Plan for AIDS Relief, and it's put about $60 billion into HIV and otherwise public health writ large. But it turns out that among the U.S. government and all the different agencies that make up the U.S. government, there's just a complete checkerboard of agencies working in global health. And none of them were doing clinical care, clinical education, clinical training. They were building clinics. They were getting access to medications. They were trying to treat people, but they weren't training the people themselves in these countries that needed to walk the halls of those clinics or needed to deliver the drugs. And most importantly, could be the people who helped see the problems, advocate for them, and begin to be implementers of change. And so we said, okay, well, why is that? Why is there not enough of, so we realized that part of the reason it wasn't happening was that it's a very complicated problem, right? The reason people don't stay in health systems is not necessarily just because they're not getting paid or there isn't the budget to pay for them. It's because they want to have their family grow up in a safe place, that their children can grow up and have opportunity. It's that they want to practice what they can train in and be able to implement their skills in the right way. It's that they don't want to see patients die every day from things that they know they don't have to die from. So we realized that we were going to have to try to solve some of those problems if we were going to help keep people in the country. And so we started to shape the program. We started to recruit folks that would go be faculty and fill those gaps that were getting created by the people leaving. And we challenged our government to say, you don't have a program like this. We think you should create it. And they said, we agree. We don't know how. We don't have the expertise. And there's a couple other subtle things that we're going to have to solve. So in the U.S., it costs, you graduate with about 120,000 pounds of debt when you finish your training, because we don't get public training in the same way at the higher levels. And so we were going to have to figure out a way to pay down that debt as well in order to allow Americans to engage in a service-based international health program. So that was another problem we had to figure out how to solve. So Seed Global Health said, okay, you're telling us you don't have the technical capacity. We can help with that. And you're telling us you have no mechanism to provide the debt repayment for these volunteers. We can help with that. And we ended up creating a public-private partnership with the U.S. government where our volunteers go as U.S. Peace Corps volunteers. So they go through the Peace Corps, a U.S. agency for volunteerism. Many of you, I'm sure, have heard of it. And what we do is bring all the technical expertise for the recruitment, selection, placement, and support of these faculty that we place in country, for the site selection of where they're going to go. But we've also partnered with the countries where we're working to talk to the ministries of health and ask what their training needs are, to have them help identify the public sector institutions where we're going to work. And we work only with the public sector. If we work with a private sector institution, they have to feed the public sector, so that we are building up that safety network and having that reach in the countries where we work. And then we work with them. And then as problems are identified, like, I really want to be able to, resuscitate small children that aren't breathing, and my barriers are, I don't know whether or not they have enough oxygen. and I don't have an oxygen concentrator to put them on oxygen when I do identify that, we've now started to leverage partners that can bring those oxygen concentrators in the place we work and to train our health professionals to understand what it means to identify, even what is happening with these clinical cases and then how to react to it. And at no fault of the physicians and healthcare workers working in these countries, it's often that the diagnosis is one thing. So, for example, you see a patient who has low blood pressure, it's TB in the adrenal glands. And that's sort of the one thing because that's what they see 80% of the time. It's the most common diagnosis, and it's the one that they've been most schooled in seeing. But the differential diagnosis of low blood pressure is actually quite vast. And so we are trying to help, break those initial paradigms for people to understand and really ask these questions of, okay, if this is how the patient's behaving and performing, this is how I'm going to try to respond. These are the things I'm going to think about, and these are the things I'm going to act on. And basically, by augmenting the faculty in these countries, we're helping to train more people, expose them to more of the clinical situations that they should be exposed to. And therefore, we're enhancing the quality of care that the patients are getting. And it's very iterative. We really ask our faculty to go and live in their communities, to listen, to learn from their counterparts, because oftentimes the solution is already there. It's just the resources and the bandwidth to execute that solution is not. And so we help provide that as well. So we started in 2013 in Tanzania, Malawi, Uganda. We, in our first 3 years, trained 8,300 doctors, nurses, and midwives. And we are now in our 4th year. We've doubled the size of the program. We've expanded to Swaziland, which has the highest HIV rate in the world of 30% and the highest HIV and TB comorbidity rate in the world. And it is also an entirely nurse-led health system. There's no medical school in the country, so while there are physicians in the country, they're trained externally and they tend to come home. But our hope is that if we can partner with the nursing schools in the country, and there's only 4 because it's a country of about 1 million, and it is a very small and dense country. So we think if we can really help empower these nurses who are right now really getting a 2-year degree for the most part in these countries, if we can help them expand that to a 4-year degree and give them clinical mentorship in partnership with the government, that's going to really enhance their ability to be advocates and providers for the patients in the countries that they're working and to become their own agents of change. And then they'll become the faculty, and we can change and support and support them, but they'll be the faculty that is now sustaining the pipeline. And if we can do that, we can have a model that we can help bring elsewhere to say, if you teach nurses who provide 80% of the healthcare in the world the following skills, this is what can happen. We've also gone to Liberia this year at the personal request of President Johnson Sirleaf, because she's the first to say that Ebola happened at the scope and scale that it happened in our country, because there were not enough health professionals to be able to sound the alarm, mount the response, and to support the community health workers and the other frontline workers who were trying valiantly to deal with this epidemic. And so the whole goal that we're trying to do is to fundamentally strengthen health systems, using people as agents of change, because they are given the voice, the skills, and the opportunity to be able to execute a sort of what is needed for their own country, and to be able to train their successors so it becomes sustainable and enduring for years, but locally led at the same time. And I think that one of the things that we have definitely run into as a challenge is that, and you're all studying this, in the public health realm, everyone's talking about access to care and increasing access to care through community health workers and frontline providers. It's critical. We have to be able to have that network. But if you don't backstop them with this cadre of health professionals to support them, to continue training, to be the referral base, you're never going to really solve the root fundamental problem. And so one of the things that we're up against, and I'd love your help thinking this through, is everyone says you're too expensive, right? Because it costs us anywhere from $80,000 to $120,000. So what is that? Sort of 70 to 90 pounds to be able to send somebody for a year and live, and to pay the insurance, and to put the grants money in to build skills labs and to do these things. Everyone's like, that's too expensive. I can train a community health worker for $25. And the thing that we're starting to ask, and if any of you want to help us ask this question and look at it, we really need help. What is the cost of not doing it? Of not putting these doctors, nurses, midwives into these countries to be able to sustainably train? Yes?
Just to make sure I understand, so the people you send as advocacy, they're just freshly out of school?
No, actually, it's a great question. So the question was about the folks we send, are they freshly out of medical school? They're not, actually. Everybody's to be fully trained. They have to be board eligible or board certified. And that's really important because we're asking them to teach, which means they have to know how to teach and they have to have been taught themselves. This is not going to be, we don't want this to be a patriarchal system of just because I come from the United States, I know more. Because trust me, we don't. We learn a lot. Yeah.
So it's med school plus the
Residency, your house officer years. So you have to go through your specialty training. And then our docs are bimodal in distribution. Some are younger and some are on the end of their career. White-haired professors that were former heads of cardiology at their university that are coming to spend a year. And then the nurses also are on that spectrum, and the midwives.
How do you bridge the gap? Because you get medical professionals who are used to high resource countries and facilities, so they be screaming like, give me this, nothing's there. So how do you bridge that gap? Because like they don't know how to do that.
So and I'm repeating your questions because the video, the question was, how do you, deal with the fact that you're bringing people from high resource settings in order to be able to, to work in these low resource settings, and aren't they demanding of things? And they are, but in an appropriate way, because we put them through a pretty rigorous orientation. First of all, we screen them really hard to figure out, are they going to thrive and survive in that, what we call the voltage change, right? And we really focus on education and training intentionally. And it's been very difficult depending on your specialty. The anesthesiologists and the surgeons really struggle because a lot of the tools that they want are not there. And they worry about giving substandard care, if you will, compared to what they know. But we spend a long time talking about this in orientation, and we spend a long time talking about it after they go. And our advice to them is don't try to do anything for the first couple months. Embed in your community. Go to coffee, go to tea, go to weddings, go to funerals, go to the OR, go to the clinics, watch, observe, listen, understand. Because a lot more is happening than you're realizing, first of all. Second of all, when you start to identify a problem or an opportunity to change something, then you need to engage your local counterpart and start to talk about it together to make sure that feels appropriate and to figure out what the barriers are to it. And once you identify those barriers, we can help you try to solve those. And so the fundamental truth is there aren't a lot of resources, as we all know, but that's not acceptable. So one of the things we want them to do in partnership with the sites and the places they're working is to advocate for that shift in resources so that we can start to deliver the standard of care that should be happening around the world. The whole point is to break down this idea that there are two standards of care. So as much as we ask them to embrace and realize they're going to be in a much less resource-intensive setting, and we try to prepare them to be effective in that setting, we also don't want them to just accept that, nor do we want them to accept it with their counterparts, because you have to embrace it, but you also have to ask for that to shift and change. So we've helped build skills labs so that if we can't do the clinical, that we can help do simulation and clinical training. We have brought in equipment in terms of EKGs or handheld ultrasound to do better diagnosis and management. We're trying to partner now with the various pharma companies to bring in the medications that are needed so that we can provide the treatment, ideally. And then cool things happen. So in Uganda, in partnership with one of our volunteers and her site, they started the idea of doing an antimicrobial resistance conference. So antimicrobial resistance is going to be the next epidemic. You're interested in epidemics? This is one to worry about. There are superbugs coming out of India right now where people have been treated by antibiotics not consistently with this. So the way resistance is built, and some of you are scientists, some of you aren't, so I'm just going to run through this quickly. Resistance is built because bacteria essentially can get exposed to an antibiotic, and some of those bacteria will survive that experience and mutate. If they get exposed to a antibiotic consistently for the full course of the antibiotic, most of those bacteria that have begun to mutate finally get hit hard enough that they just die. They do die, and so they don't continue in existence with this resistant gene. But if you give an antibiotic for 2 or 3 days and then you take it away, those bacteria don't have that continuity of treatment in a way that they get killed off and they get resistance and then they spread. And that's when we get in trouble. So there are bugs coming out of, fortunately they've been primarily in Southeast Asia and India at this point, but they're essentially global because we just had a couple cases in my hospital, Mass General in Boston, and it's $1,000 a day in antibiotics to try to treat these patients. And we are trying very quickly to try to develop new antibiotics, but if you look at the resistance patterns, it's quite startling. So Uganda realized that there's not been a consistent enough drug supply to allow consistent treatment of antibiotics appropriately for diseases that they have been treating. And they realized that they're at risk of having this happen, and it will be devastating when it does. And so they organized a locally, sponsored conference on antimicrobial resistance. And we helped support by providing funds to support the conference, getting faculty, helping to produce that, because that was a joint learning experience that they could have. So these are ways that we have found that you can be effective even in the absence of full-on resources, but you can begin to bang that drum and make that call so that people will join and it becomes known and it can become something that you can solve. A story I think that also is very emblematic is that we have a medical student named Ali Asghar Kaki. He's Tanzanian born. And Ali Asghar went through some time in rotation with one of our family medicine volunteers and he learned neonatal resuscitation. He was on a different rotation, and Tanzania is still a fairly hierarchical medical system. And he was on another rotation. As a medical student, they passed a baby who was not breathing. And everybody, including the prof, kept walking, so that baby has died. And Ali Asghar, maybe the professor wasn't there, but whoever was above him on the food chain was there. And Ali Asghar says, there's a protocol for this, and we know what to do. And he went and realized the baby still had a pulse, and he resuscitated the baby. So no new equipment, just knowledge and experience allowed him to save this child. And he realized that was the power of knowledge. And so he organized trainings around his hospital and trained over 200 people in his hospital with the same skill set. So he leveraged that and trained others. He's now organizing trainings around Tanzania. And if you ask him what he wants to do when he finishes training, he'll tell you he wants to be a Tanzanian doctor who stays in Tanzania and trains others. And that's part of the impact we can have even in the absence of resources. But we still have to demand those resources, because the thing that we fundamentally hold on to is that it is 2017 and there are two totally standards of care in the world. And just because one has been allowed to exist for this prolonged period of time does not mean it's acceptable, okay, or should be considered the norm. And that's what we're trying to help push back on. You had a question? Putting you on the spot. We can come back.
I have a question. So how do you guarantee the retention of those health workers in the national system? Because I know that some of them, they will have the willing to stay, but after that, when the government doesn't invest into the health system, they will go to other countries. Like in Southern Africa, it's quite common that people go to South Africa.
Or now Rwanda.
Yeah,
Don't underestimate your country. It's a wonderful place. I actually was just with your former Minister of Health and Vice Chancellor of the University of Global Health Equity, Dr. Binagwaho. I was with her in Oxford just now. That's the $10,000 question, or more probably, which is how do you keep your healthcare workers in these countries after you train them? This is the thing that keeps me up at night for the most part, because as much as we can pull all the levers and train people well, if they don't have those other pieces fall into place to keep them there, that is very difficult. And it's really an important question, and we're trying to solve for that even at the policy level too. One of the things we know from data that's out there is that many people want to practice. It's not just money or financial remuneration that will keep people in a country. Obviously, they need to earn enough of a wage to feed their families and to live. But if you can provide satisfaction in the job, so arm them with the tools they need to save lives and to, make a difference, that can help. It can be things that we control and don't control, like building schools for children, so that their kids can get a good education, or providing housing is a big thing about retention in the rural areas. And so we've been trying to engage the government on a more policy level to say, if we're going to do this, we need you to help us, keep these folks and to think through what the policy, how we can affect policies and pull levers. And we're very excited because we've just been asked by one of our partner governments to helped place a technical advisor in the ministry on human resources for health to help think through some of this stuff. And that's one of the things we're doing. Part of the reason I give talks all the time is because I'm trying to raise awareness of this particular issue, and the WHO has done a great job trying to highlight it, but now we also need to highlight it among us who are implementing partners, because we are the ones that often get engaged in conversations with donors, with governments, with our co-partners, to try to figure out how to solve for this. And so things that we're trying to do is to really change the experience of giving care and the experience of learning, and to make the job, at least, like, rather than having 200 students whose exams you're grading, if we can cut it down to 100, it becomes more manageable because we can help you divide that work. We're building skills labs so that they can do continuing medical education and practice improvement, and then they can teach in that setting. We are trying to bring in equipment. So the handheld ultrasound's been really successful. We partnered with GE to bring handheld ultrasound to most of our sites. And that now is a diagnostic tool. It's a teaching tool, because then you can see in real time. You're not just listening to the heart, but you're seeing the heart and what it's doing. And it becomes a management tool in the patient. Is the patient getting better? Is the patient getting worse? You don't have to worry about sending them off to an X-ray or moving them. You can do it right there at the bedside. And that, I think, has allowed people to be very empowered in what they do as well. I mean, that is a single grain of salt or sand in an entire desert, but it's these little things that we hope to show the value to. If we can all do, we can accrue this evidence en masse, we can begin to start to shift things. But it is going to be reliant on smart solutions too. I just learned about somebody who is using tablets that have very complex algorithm to allow community health workers to make the correct diagnosis 85% of the time. We're going to need those things as well. That at the end of the day, many people are trying to think about those other solutions, if you will. There are not many people working on this space of the health professional that is so critical to holding this whole system up. And that's the space that we're trying to work in. Yeah.
So you're looking for the counterfactual, if I'm getting this right. And you chose Uganda, Malawi, and Tanzania as your first sites, but why did you choose those countries?
So we chose Tanzania, Malawi, and Uganda as our first sites. We started, first we knew we wanted to start in sub-Saharan Africa because it has a quarter of the world's global burden of disease and only 3% of the world's healthcare workforce. So even though Southeast Asia has more burden of disease by population, if you will, it has a much larger, it's still not enough, but it has a larger relative workforce. So the gap between the workforce and the burden of disease was quite high in sub-Saharan Africa. Further, there's only 1% of the world's healthcare expenditure in sub-Saharan Africa going towards workforce issues, or towards health, period. So that gap also very much existed, and that's what drove us to the continent to begin with. When it came to countries on the continent, we had a pilot program, and we had a ton of U.S. funding behind it, and we didn't want to screw up, is the honest truth. So we knew we had to pick countries we could succeed in, and that meant countries that were already asking questions about medical and nursing reform, countries that seemed to demonstrate commitment to this kind of, investment and were willing to put some skin in the game and truly wanted us there. And then it meant going to the countries and saying, do you want us here? Some countries said, well, we've got all this other programming going. We need to figure out what we're doing with that before we take you. And then there was the reality of the fact that we wanted to do English speaking. We were bringing English native speakers. We wanted to have that plug-in point. I mean, they do learn Chichewa. They do learn, Uganda has 52 dialects. So it's very difficult to map all that. But the ones that go to the Southwest learn Runyonkole, and Choli up north in Gulu. So they do get some language training. Tanzania is easier. It's, Swahili. And so we have one that did an entire radio interview in Swahili. I couldn't believe it. I mean, so they do get fluency in it. Liberia is totally English. Swazi is primarily English. And to be candid, most of the providers that we work with who are indigenous to there have issues with dialect with the patient. So there's lots of translators around as well that have been helpful. But English speaking, so we weren't going to Mozambique, right? We were not going to go to French West Africa at this point, or Francophone countries. And then because we had the U.S. government as a partner, it became a little bit up to them where we ended up. And so they would go to their missions and they'd say, so we wanted to really go to one unnamed country that we thought was like the perfect partner. Government, this was the government's goal. And our U.S. mission was like, we have too much going on. We can't take another new program to launch. We're actually ironically going to go there now next. But I don't want to call the country out or the mission, so I'm not going to tell you. No. Ghana's been fantastic. Are you Ghanaian by birth?
Yeah.
I lived there for 6 weeks.
There, that's
Are
why-
you?
but we are going to-
Ghana's actually in great shape from a healthcare workforce standpoint, not relative to the other countries. Let me always put things relative. And you've had a very, my opinion, you had a very fantastically progressive government about addressing workforce issues and had a lot of creative partnerships. I'm also very partial to Ghana because my first job in global health was, I lived in Ghana and was working in Accra. And I knew every polyclinic and it was just great. But so Ghana's not one of them. But sorry, total side note. So we had to be careful about, so that sort of helped dictate. And then really 3 countries bubbled up, and that was where we ended up. Now, we were so successful in our partnership with the U.S. government that in World AIDS Day 2014, PEPFAR announced a $16.5 million expansion of the program and continuance. They wanted us to expand in the 3 countries we were in, and they wanted us to go to 2 new ones, and that's how we ended up in Swaziland and Liberia. And those were pretty straightforward ones for us because Swaziland had the highest HIV rate in the world. PEPFAR is an HIV funder, and they felt like if we're not doing it there, like, you know, we got to really tackle that. So that was one. And then PEPFAR, despite being an HIV-focused agency, recognized that unstable health systems, weak health systems, and epidemics run the risk of allowing HIV to thrive and propagate because you aren't being able to put the systems in place to empower people to make choice, to have access to care, prevention, and all these things. And so they wanted us to go to West Africa. So then it became a question of which West African country. And Liberia had a really robust human resources for health plan that they had actually developed before the Ebola outbreak happened. And it was a 10-year plan to scale up all their human resources for health and provide access to every person in the country for care. And that was reinvigorated very quickly in the wake of Ebola. And we were one of the only organizations that focused on training of the health professional. So we got very quickly asked to come in and play that role, and we're very proud to be there. Yeah.
Can you talk a little bit about the challenges you found in the organization and also how you got the government support, how all of that worked out? And then the second question, what do you do now? Because you're still a physician, I think, right?
Sort of.
Are you based in Boston? What's
Sure.
your daily business?
So the first part of the question is sort of the complexities and difficulties in starting our own organization, sort of how we have gotten to where we've gotten. So we started as a grassroots movement. We saw a problem, and we started to think about it, and we started to ask questions, and we started to write about it. And we got published in the New York Times on the op-ed page, and we got published in the New England Journal of Medicine. And that gave us an incredible platform. And I think that was just a very simple thing that anybody was capable of doing. And we did that, and we were very pleased because that got us attention on a very big way. And people started to come to us and say, we've been thinking about this for 10 years and it's never happened. Why do you think it can happen now? And our answer was simple. Literally, someone had tried to legislate for it. The same idea, sending Americans abroad to teach, to train, building this global health service corps. And we said, the difference is it's 10 years later, and now the intersection between health and global security is much more understood. We know that health is a requisite to our socioeconomic well-being and also to actual true stability, markers of peace. Tom Daschle, and this actually postdates the time we were having that conversation, but it's an important data point. Tom Daschle, a former senator in the United States, and Bill Frist, a former senator in the United States, from 2 different sides of our political parties, came together and just issued a report looking at how PEPFAR investments have, in the countries where they have invested, governance has been improved, they are more stable. On the markers for peace and stability, they have gone up, and it's one of the most seminal studies that has looked at that linkage between health and stability and governance, and so I just highlight it because it's a good one for you. It's like your Whitehall paper, right? That, I think, is going to be the equivalent of that. So we knew that conversation was already happening. The winning hearts and mind thing was, though being played out in the U.S. military, it was something that resonated and we could capitalize on. We also knew that previous efforts had tried to legislate. God bless my country. But even back then, Congress was so at war with each other, there was no actual discourse transpiring. We did not think it was realistic to legislate. You would need total alignment. You would have needed complete control of the Congress and the presidency in order to see something like this go through. And so we said, don't try to legislate, but go directly to the agencies that come out of government, right? So who were our agencies? We had the State Department that was funding PEPFAR. We had the CDC. They do epidemiological survey and sort of the science behind it, but they weren't going to be a deployment candidate. They might be, but they were still around data and information systems, if you will, and the public protection of population. We were going to potentially use that argument. There was NIH, but they do research. So the National Institute of Health primarily does research. So we were searching for a home, and we realized the Peace Corps was a natural home, because when President Kennedy started the Peace Corps, it was a vision that he delivered in a speech in 1960 when he was then a candidate for president. He stood on the steps of the University of Michigan at 2 in the morning, and he gave an impromptu 3.5, 4-minute speech that his handlers, as I call them, didn't remotely want him to give. But he spelled out the vision and asked, who of you who are willing to be doctors are willing to spend your days in Ghana? And so his vision was originally to put medical providers into a situation of teaching and exchange. That never formalized in Peace Corps. It was the Peace Corps' 50th anniversary that year. So we realized we could capitalize on that too. So the question became, how do we get to Peace Corps? My colleague, who realized that the Peace Corps was coming to Boston, where I'm based, and so we went to the forum with the then Peace Corps director, and we just stood in the rafters at the end of the forum, and we raised our hand, and we asked publicly, what do you think about the Peace Corps sending doctors and nurses abroad to be educators, to teach, train, and build capacity? And the public answer was yes. So then we elbowed our way to the front of the room, which I don't think they expected, introduced ourselves and said, you know, we were lucky. We had a bit of branding behind us. We were Harvard-based physicians. We said, let us come and talk to you about it. And we used all the people who'd been thinking about this for 10 years, and we built a coalition that went to D.C. and started to talk about it. And then the Peace Corps said, it works out. Turns out our countries want more technical capacity than we're giving them. But here's the problem. We don't have the technical expertise, and we're not going to be able to build it. And we recognize that American health providers are not going to be able to do this program unless you give debt repayment. And we said, we'll help you solve those two things. And then the program was born. It was totally iterative. We were all terrified by the seat of our pants. Next thing I knew is, as a physician, I suddenly was mostly responsible for $10 million US and how we were going to spend it effectively over 3 years. So we just got really honest. If things weren't working, we fixed it. We were honest about it. We troubleshooted for it. We asked for help. We tried to learn from previous mistakes as quickly as we could. We told our volunteers, you are our pioneers. Our first class, we called our pioneers. We said, you are helping build this program with us. You need to tell us what works, what doesn't work. You need to tell us like where we've totally blanked up, you know, and sort of screwed up. And we just learned quickly. And we've made mistakes. And I will tell you, right now is a terrifying moment for us. Terrifying. Because as much as I thought we had prepared ourselves for any change in administration, I didn't anticipate somebody who would be so sweeping in the reforms that he would make. And we feel incredibly vulnerable because he could decide with the sweep of a pen to destroy this program because he might destroy the Peace Corps. He might cut our funding. He might decide that, you know, we are liberal volunteerism at its worst and he doesn't want to see it go forth. And our biggest part of Seed Global Health's platform runs through the Peace Corps because it's the most economically efficient way to do it. We do have a pile of work that is outside the Peace Corps that we have been growing and diversifying. And our dream for expansion is to partner with the UK and DFID. Bring your physicians and nurses here to spend a year and work, and then with the goal that they come back and they invest in the NHS and are better clinicians and better educators and better understand the root causes of disease to help shift the system here. We're seeing that in the States. To partner with France, to go to Francophone countries, or Portugal, to go to Mozambique or Angola. Because at the end of the day, Europe is the only region in WHO that doesn't have a shortage of healthcare professionals, actually. I guess the UK does, and this has been an issue, and technically you're not Europe anymore, but 2 years, I know. So no offense, I have to say, it's misery loves company, so I'm very sorry. It And so our goal, that's our goal. Our goal is that a corporation says, we're going to pay for this program to happen for doctors. And then the real dream is we train enough folks in Zambia or Tanzania that they can go help. But a couple things have to change. We as a community and a culture have to decide that we are going to tolerate a long-term time span for a solution to actually be seen and resolved. That we're going to make big investments. Because again, it's not how much does this program cost, it's how much does it cost not to do it. And those are the shifts we're going to have to make. And so the challenges have been immense. We had to change bureaucracy at Peace Corps. Peace Corps wouldn't let our folks drive because nobody in Peace Corps can drive because that's how you die most commonly on the continent of Africa, unfortunately. And so to help protect lives, they don't let folks drive. Oftentimes, because if you're also driving, it's like when we come here, my instincts when I'm about to get in an accident is to swerve right, but unfortunately so is a Brits, right? And that doesn't make for left in your case. That doesn't make for a good combination. And those types of little things are part of what had led to accidents. No one was allowed to drive. We had a problem because our OBGYNs would be on call overnight, and they'd be waiting for a taxi. They'd have to take a bus. Nobody showed up on time, and it wasn't working. So we actually managed to get Peace Corps to change its policy to allow our folks to drive. And now we're an incubator for Peace Corps to see if the things that we've put in place can actually be implemented elsewhere in the program. So we're not trying to be exceptional. We're just going to be on the leading edge. That's been a challenge. Funding is a challenge. Community health workers are sexy. Like, I know it sounds ludicrous, but everybody gets that, right? It's pennies on the dollar for the effect that you can have, and that's wonderful and powerful. But it's not sustainable in and of itself. I tell people how much it costs to put a volunteer in the field, and their eyes glaze over. I tell them how much it costs per person trained, $880, so what, 600 pounds? That's nothing. Think about the fact that each of those trainees, if they've enhanced their quality of care delivery, let's just say they do 100 patients, right? I've been on wards that are 80 patients thick on a given day. So we know it's more than 100 patients. But if it's only 100 patients in an entire year they affect, those trainees, that's $7 or $8 or 6 pounds per patient. The costs start to diminish. And imagine if that leverages over time, over years. But making that argument has been a big challenge. I spent this entire week at a conference trying to convince people, as much as they should be investing in silver bullets, they have to dive deep with us and help us bring this to scale to implement those changes. Which comes to my own personal journey. I trained as a physician. I went to medical school. I went through my training. I started SEED. And as I started SEED, I realized I didn't want to be a general practitioner. So I went back to fellowship. I just had my first child. It was like the dumbest plan. I went back to training with an infant child, starting SEED, and everything was just to hold your breath and get through the day. And the hours were long, and the days were way too short, it felt like. And I became an intensive care doctor, and then I thought, this is perfect. I spend a week on, and then I'm off for a month, and then it's a week on, and I would do 8 weeks a year, and I would teach and train, and I loved the physiology, and it was amazing. But then the pressure started to mount. We've started to get bigger. We realized that we have to do more to grow to scale. The need is immense. I never feel like we're doing enough. I have 2 kids now. The travel's immense. And then Trump got elected president. And I suddenly realized that that was the straw that broke the camel's back. Because I was already I knew I was sliding to giving up my clinical practice. I just thought it was a couple years away. And then when he got elected and I saw what was on the table and I realized everybody that was at risk and I realized that I fundamentally am going to be fine, I will survive his presidency. Many, many other people won't. And I just realized that I could be a doctor to 1 or 10 or 18. Or I could go all in and support our staff and support our 34 sites that are at risk and try to grow this movement that we need to be a part of. And so I literally, if you'd asked me 3 weeks before, I never would have told you this was even on the radar. I walked into my chief's office and I told him I had to walk away. Did my last shift in January, or my last week in January, and I will still be a doctor. I'm going to go back to probably doing urgent care with immigrant populations a couple times a month because I think it's really important to remember the vulnerability of the patient interaction, and that I hold dear to the work that we do. But it's a real identity shift, and it's been very surreal and strange, and that's been hard. The personal side of this is almost harder than the organizational side. because the organizational side, we've got a team. We've got 29 people who are in this with me, and that makes it really easy. Because when you're having a bad day, somebody else can lift you up, and you can problem solve together. No one else is a mom to 2 kids and a wife to my husband and feeling responsible for the 29 people in the organization and trying to make this all happen. And candidly, that's the part that I struggle with, that I think I struggle with the most. Because the organizational things, they scare me. Those scare me more. But I have much more confidence that we know how to fix those things and to fight, and we have more voices, and we're really in it together as a family. And I hope by talking to folks like you, your brain wheels are all going to be turning, and you're going to walk out of this room and maybe not solve my problem, but solve another one. And that is a big community that gets to do that. Long answer. I'm thinking a lot about it now, as you know. It's been a journey. Yeah.
So a lot of our alumni will be watching this video, and they'll be based in 180 countries around the world, including the countries where you've got sites in the US and stuff. Is there anything our alumni community could do to support the work that you're trying to do?
Absolutely. I mean, I think this alumni network is without doubt extraordinary. There's so many ways. Actually, I could see linkages. One, as alumni are in these countries, if they're in countries that have a lot of resources or the ability to mobilize resources, it's very helpful to have them help us think about how they can plug into the health system. And sometimes it's architecture. Building a hospital that has appropriate ventilation for TB is a tremendous thing. Sometimes it's bringing art to the children's ward so that they can heal and actually, recover from the trauma of being sick and in a hospital. Sometimes it's just mobilizing resources and saying, I'm going to make a donation to Seed Global Health, or to say, I will help partner with you. My friend runs a pharmaceutical company, and we think we can leverage those drugs. Or it is one of you or one of them saying, I've got a bunch of PhD students that can help you do the impact analysis you need to show the worth of what you're doing. I mean, so there's always a way to try to plug in and to think about this. If they're a physician, a nurse, a midwife, we welcome them to come. If they're a lawyer, we want to start a legal corps to address health regulation in these countries and to teach, though, the capacity to have that locally in these countries to do it themselves. Because we make trade agreements that we make the price of cotton exchange better, but we sacrifice our access to drugs. And that was the one thing that I walked away from with Elias, was that listening to that was just extraordinary to me, because it opened my eyes to a lot of the complexity of this. And so that's ways that they can help. A school like the London School of Hygiene and Tropical Medicine, though, can help, because let's say we do build a partnership with the UK, offering certificates for global clinical education, or recognizing the academic value of what these folks are doing when they're teaching and training and living for a year, changes the conversation about the value of service. And doing something like this, which one, makes it more attractive for people to participate in, but also adds value to what they do when they come home, can keep them on a promotional track in what they do. That's an easy, no-cost win for a school like the London School of Hygiene and Tropical Medicine, so that there are immense ways that people can plug into this bigger problem. And again, we are but one block in the World Health Organization's 6 blocks that make up the health system, right? Health information systems, technology, service delivery, governance. Help us fix all those, and the whole system becomes more functional too. Yeah.
I was wondering, how about you Americans, and getting actually American physicians is very expensive because of the debt repayment.
Mm-hmm.
But why don't you include physicians who don't have debt repayment loans?
We do. So we recruit broadly in the United States. So the reason why we started with the U.S. again was the Peace Corps is our partner. You have to be a U.S. citizen. So recognizing that, we offer debt repayment of about £20,000 so it's $30,000 for each year served. And it's offered to everybody. You apply on a needs basis. About 80% of our volunteers actually need it and take it. 20% don't. And so we love those folks because our cost goes down significantly. And somebody actually said to me, one of our board members said to me, well, shouldn't we just be recruiting them? And I was thinking, yeah, but then you're missing this whole, and there's also, I think, a spirit of investing in young change makers that go have this experience and bring it home. So, but our goal right now is to target health professionals that don't have debt, which is primarily outside of the United States. So we want to partner. We just had meetings with DFID earlier this week to try to convince them to help support us. We'd love to plug into your medical societies and nursing and midwifery societies here to think about how they can help us mobilize people. Germany, I would love to talk to the German government because I want to see if we can partner with them to try to be able to, help us and we want to talk to the French. We want to talk to the Swiss. We've talked to Norway. Norway just changed all its financing, though, so they really only give through Gavi and through the Global Fund, and then they fund their independent universities. So we actually now have to leverage each individual university in Norway to make that work. It's on the list. We'll get there. This is what we want to do. So, but I need money to build my European team. Right, but to build my European team who can lead on that and be the liaison here, because I can't keep coming over the pond to do this. And so, yeah.
But so as long as the program is so dependent on the Peace Corps, there's no way for you to take non-US.
Oh, we do. Sorry, so thank you. The punchline to that is we've actually grown sending volunteers outside of the Peace Corps. It is dependent on the Peace Corps because we use them to get the model up and running in a cost-effective way. But we actually know how to do it. So there's a lot of learning and ways that we know we can do this to scale, that we don't need that infrastructure anymore. In fact, to be honest, at times it's exhausting, that infrastructure. And so we can build it, I think, very economically to send non-US health professionals. And we've had a number of people interested. And we're desperate to, again, it comes to funding. I do have to pay a salary. I do need to ensure you have medical insurance and evacuation insurance. I do need to ensure that you have the fundamental support you need. I'm going to have to expand my grants program because if you go, I want to empower you with the tools you need to be effective teachers with your counterparts. So that costs money. So I need a pilot fund just to build the European team to put this together. And then we're going to need the funding to send the folks. We know how to do it. It's just a question of getting those pieces in place. And we think it's absolutely the way we're going to get ourselves to scale. Mm-hmm.
Who's funding your organization outside of the government? Because you talked a lot about the US government funding it, also did it. If you're looking into having UK government funding it, but do you also accept private donations or you're partnering with the WHO or other UN organizations?
Yeah, absolutely. So so I think just on the clarification, if we go to DFID or we go to another government, it's not to fund the Peace Corps program. It's to build a parallel, model based on the tenets that we know work. So we want to be very strategic about how we leverage existing models and tweak it to be the most effective. And so that's part number one. Though we get some U.S. government funding, it's only about 20% of our budget. So we've built a $6.3 million organization now, of which we get the, 3/4 to, 80% of it is indeed actually from private philanthropy, from corporations, from events that we throw where we just ask people to give. It's like philanthropy 101. And then I trained as a doctor. This is like not my world. So I have been learning how to do that and what it takes to do that. So that's a huge part of how we function, actually, is through giving. In-kind donation is another way it happens. GE donated the handheld ultrasounds. We didn't have to buy them. That was a great gift. So we really try to leverage philanthropy to make our how we go, what we do grow, and to be able to fund the programming. And so that's how it's happened. Yeah.
You've discussed incentives for U.S. medical doctors, such as the debt repayment and also maybe certificates from places like LSHTM to go and do these global rotations. But how do you also keep them ethically accountable before, during, and after the training by ensuring that they're understanding local contexts, history, perhaps traditional medicine and community health workers?
So we screen them pretty carefully. We actually do Skype interviews if we can't meet them in person because we want to see their body language and who they are and how they present, which I think is really important in understanding the fabric of someone. We walk them through some really rough scenarios to see how they would respond, and you can genuinely tell the depth of response or thoughtfulness or someone's willingness to say, I don't know how I'm going to deal with that is one of our greatest answers because it means they don't have the hubris to think that they have it all figured out. And so we do that. We put them through a pretty intensive group orientation in Washington, D.C., where we talk a lot about these issues again. We bring in our alumni to talk. We bring in our country representatives to talk so they can hear the local voice. And then we have them spend another 2 weeks in country doing an in-country orientation, understanding the medical education system, nursing education system, understanding some of the cultural history and context and background that affects what's happening. And then, and so we really try to ingrain that in them. But they're embedded in a community that tells us if somebody's screwing up. So we've had a couple of volunteers where we have heard they're like a bull in a china shop. And that's when we have our country reps sit down with them and intervene and really try to discuss, what's going on. And we've never actually had to remove somebody. We've talked about it a couple times, but usually people come around. Most of these folks, we've never had a problem yet. I mean, there's going to be one sometime. But there's enough people there who will report back to us. And we have close enough relationships with the sites that we're working that they now will say, and every culture is different, right? Some of the countries we work in, they'll say yes. You have to watch very carefully how exactly the head nods to know if it's a no or truly a yes. And it's cultural. But the problem is that I come from America where we just tell you like it is, right? You're Danish, right? It's one of the most, Dutch, sorry. Excuse me, I meant to say Dutch actually because I'm envisioning the Netherlands in my brain. One of my best friends is Dutch, and when I went to medical school with her, and when she moved back to the Netherlands, she told me she'd forgotten how straightforward people were. And I'm thinking, really, in the States, we're so straightforward. And she told me, maybe not, I don't know. So at least where I work, we are. So I feel like people are overly blunt. But the cultural nuances are rough, right? But we've started to forge these relationships in ways that we've been able to work through that. And so people tell us, and we need that, right? We're not going to, again, this is what I'm saying, we have tried to be so open about where we screw up, because then we can fix it. We don't know.
How structured is the training that the volunteers provide in these countries? Do you know beforehand that there's a need for a particular skill or a particular service, and then, say, improve surgical practices, and then you send surgeons out there to show how to improve it in practice in theatre, or do you kind of send them there and then they just, from the environment, see what's going on and then impart their wisdom?
So the way it works is that we, in partnership with the ministries of the countries, have identified the training institutions we want to go to. And then we partner with those training institutions in that they identify their needs and priorities, and then we try to skill match to those needs and priorities. All these countries have national curricula. We're not in there to revamp those unless asked. And so what we do is we work with what is there. And then we see how we can plug in, augment, help strengthen. And one of the greatest things we do is not so much curricular change, but teaching people in a clinical setting. So I will tell you, medical students I have worked with in the African countries that I have worked with are some of the smartest, most engaged, understanding people. If you ask them to put on the map or like to map out the pathway for hyponatremia or low blood sodium, they'll do better than any American medical student any day. Where the breakdown happens is when you put them into a clinical ward. Because ministries of health pay you to work in a hospital. Ministries of education pay you to teach. Nobody pays you to teach in a hospital. So you're asking providers who don't have enough time in the day to make their livelihoods, care for their family, and do all these things. Then you're saying, oh, by the way, you also have to go teach for free? It doesn't happen. So there's a breakdown in clinical education that happens in the clinical setting. And that's where we've been able to add the most value and plug in. And it's been tremendous seeing what shifts, because suddenly people understand, oh, I understood that in the classroom, but now I get how to do that in the patient, and suddenly patient outcomes can change. And so it's not necessarily even having to change the existing curricula as much as executing what exists and helping to offload faculty so that they can pursue their studies again, get up to date, not have to, if it needs be, even build some time for them to earn some of the money that can keep them teaching in the public sector at the same time. And so that's part of the value that we add. Yeah.
To what extent can you be critical if you're in a country, because you're invited to some extent, and you're working with governments, but can you criticize situations, or are you more trying to engage with them and kind of hint them to change certain things?
Depends how well you know them. I mean, I think that for us, we've only been there for 4 years. So my ability to be critical is usually on a human rights issue. So when Uganda passed its anti-gay legislation, we did speak up because we felt that that was a patient care issue. Access to patient care, providers feeling safe. We felt that threatened fundamental, abilities in the country. And that was something, and we based it in science though, right? So we were using evidence-based fact. It's very difficult for me, who does not live there and doesn't, to come in and be critical. Part of the reason we've hired country representatives is not to let them be critical, but they're going to understand the nuances of a situation far better than I am. And we want them to exercise their voice and help guide us on how we can help support a solution. And that's the approach we take. Is not, I think that we really try to think, one of the reasons we have been successful is rather than being critical, we have always, even with our own government, we've always tried to say, okay, how do we get to yes? If this is the problem, if Donald Trump does not like volunteerism programs, then we don't talk about that. We talk about the fact that we're investing in health systems to make America safer. We're talking about the fact that when we take $1.1 million to treat 2 people in the United States for Ebola, we could be shutting down an epidemic in West Africa so that we don't even have to have people, right? So, you just figure out how you get to yes. And I think that that's the attitude we've tried to take. And trust me, there have been moments of frustration where I have thrown things, but it's always behind a closed door. And it's more to vent the emotional response, because you have to, and there's a balance there. And we're constantly struggling with that. But it is for us to help think through solutions and to be partners and to think about how we can improve what's happening. And that's the approach we try to take. There's a question up front, but I don't know. Or did you have one? And then we'll go there.
I was wondering, because he shut down the UNFPA fund already, and they have good counterfactuals. So they have good data, basically saying if you shut us down, this is how many people are going to die. And
I didn't say our government, right? I said, no, I'm kidding. Go ahead.
Yeah, how do you, because I get what you want to do in creating a good data, basically telling your program's needed and in that scale and that amount of money, but what happens if he's not interested? From a political standpoint, for example, UNFPA has good data saying they're really needed.
So I think our government, so you're right, there are governments that may make decisions based on values over what we would consider important facts. And our government is not alone in that right now, but that's a really real struggle. And I think for us, so you have to be, your voice is to be critical. You are critical from a science-minded standpoint. It may not change opinions, but you're putting fact out there that hopefully people will revisit and return to. The other thing that you have to do then is to galvanize the public sector to step in and fill those gaps. And that becomes all of our mission to engage in that. And I think that the only thing I know how to do right now with what's happening, the only place I know how to go to is to remind myself, I'm losing the steam on this one, but so I go back to the place of so I don't personally politically align with our current president. And so I have to ask myself, how did he get elected in our country? And I've had the privilege of going to 45 out of 50 states in the United States. So I've had a chance to really see a lot of who we are. And I actually could have told you before the election he was going to win, because I knew a lot of America was really hurting. And so as much as President Obama was a candidate for change, so actually was Trump. And I think that people were hurting. And he talked about, despite being a very wealthy elite, he talked a populist talk of not continuing to perpetuate, elitism in our country and to giving things back to the people and to the state. And it all sounded like it was more accessible. And people voted for that. So why did they vote for that? This is where I have to make my peace. It's because they're fundamentally motivated by the same thing I am. They want opportunity. They want an education for their kids. They want access to health care. They want to know that they're going to wake up tomorrow and be okay. And if I remember that, I can be a lot more peaceful about what we've arrived at, only in the sense to say, okay, it's not that America is dumb and how could they vote for him? America is just actually hurting in a lot of places. It doesn't have a voice, and this felt like a voice for them, and that's why they voted for him. And so then it becomes, how do we change that experience for them, right? That's where the problem actually is, not Trump, because we have what we have now. And we can fight against it all different ways. But for me, then it becomes about education, opportunity. So President Trump had said that he wanted to cut NPR, National Public Radio. Well, it turns out NPR employs a lot of people in Republican states where they otherwise wouldn't have jobs. And it turns out that Republicans, population and constituencies actually rely on NPR as their only news source. Suddenly NPR is not necessarily going to get shut down. I mean, that's the rumor that I've heard. I don't know that to be true. Nothing feels true anymore, right? But if that's the case, I'm hopeful of what can happen. And so for me now, when it gets to the bigger picture of government, I'm still committed to trying to work with this government. I will be critical, but I will be fact-based in doing it. And I will be resourceful in partnering with public and private sector, because I will build the evidence base when the next election comes. We can inform people what the truth is, and they can make an educated decision as they thought they were making now, but one that is truly empowered with information next time around. That's the fight. And it's a fight in all of your countries, because we are seeing turbulent elections happening around the world. So we all have to be engaged. And it's as simple as listening, and I really can't underestimate this enough. Just because somebody feels like they are totally different and have a different political, and I'm not being trite when I say this, please. Just sit down and engage them to understand their motivation. And I bet you there's a lot more common ground than you realize. And understanding that will allow a lot more conversation to happen. Yeah.
When you talk about how in your own country there's a lot of stuff going on, where is your motivation to still go outside and do something outside of the United States instead of starting programs or projects in your own country?
It's a great question of why we're not domestic. So I have a two-part answer to that. One, we do have a lot of problems in the States, there's no question, and there's folks that are working on it, and I do want to be a part of that solution as I can be. My personal interest and sort of focus has been international, in part because I grew up in a family of parents that had grown up internationally, and that had given me an outward focus. And there's a lot of really real need, obviously, where we're working that just personally motivates me. I am very pained, though, by what I'm seeing in my own country. But I do believe through the work that we're doing, we are making an investment in the United States twofold. If we strengthen these health systems where we are working, then I do think systems become safer, markets grow, everybody benefits. And to be very, very sort of narcissistic, right? If you don't have Ebola in West Africa, we don't worry about it in Dallas. You know, I have to say, I could not believe the response we had when there was a single case. It just was absurd. But if I use that argument, right, we're all safer if we make healthy health systems, because pandemics move across borders like crazy. And if we aren't building the whole system, we're going to be as much in trouble as well. And I think there's reverse innovation that comes from it. Using ultrasounds at the bedside, I was one of the only critical care doctors that used ultrasound at the bedside in our ICU, because I knew the power of it